Good evening to everyone. Today's topic will be the approach to solitary thyroid nodule. According to American Thyroid Association, thyroid nodule can be defined as a discrete lesions within the thyroid gland, radiologically distinct from surrounding thyroid parenchyma. Etiology can be of benign and malignant. Benign includes follicular adenoma, colloid cyst, simple or hemorrhagic cyst, lymphocytic thyroiditis, granulomatous thyroiditis, and malignant includes papillary, follicular, Hutchinson cell carcinoma, medullary thyroid carcinoma, anaplastic carcinoma, and thyroid lymphomas. Coming to the topic of solitary thyroid nodule, it is same defined as discrete lesion in thyroid, clinically and radiologically distinct from surrounding parenchyma. It increases with age and it is more frequent in women. Its prevalence is 4% by palpation and 19 to 67% by ultrasound examination and 50% in autopsy series. These clinically non-palpable nodes can be detected by ultrasonography, which increases the prevalence from 30 to 50% in greater than 60 years of age. And most of the nodules are benign, which constitutes about 85 to 90%. Coming to clinical evaluation, history of thyroid nodule is very important as most of the thyroid nodule is often discovered incidentally during the clinical examination. The data which should be included in the history are age and gender. Around 20 to 50% of solitary nodules in patient younger than 20 years of age are most of malignant. And as said previously, female thyroid nodules are most frequently seen in the female patients. Coming to size,
No,
the
Praveen. Why is gender important?
so it is more frequent in female genders,
Okay, that
thyroid
is
nodules.
that is okay. Most frequent, but what is its relevance with respect to solitary thyroid nodule? Whether if there is any in males, is there some difference? Solitary thyroid nodule in males?
So, risk of malignancy will be more in males, sir.
Yes. That is why gender is important.
Yes, sir.
Go on.
And coming to size, the incidence of malignancy will be higher in nodules of greater than 4 centimeters, and all nodules of greater than 1 centimeter and non-palpable nodules with clinical or suspicious imaging requires further evaluation. So size is also an important part of evaluation. And coming to rate of growth, usually non-neoplastic goiters are slow growing over years, and if there is very rapidly growing nodules within hours and with pain, it suggests of hemorrhage into an existing nodule. And about 90% of hemorrhagic nodules are benign and only 10% are malignant. And if the rapid growth is over weeks, it is more suggestive of malignancy. And if there is any sudden change in size of a pre-existing nodule, it also indicates a malignancy. And if the size increase is greater than 3 centimeter within 2 months, then we can suspect lymphoma, anaplastic thyroid carcinoma, or metastasis to the thyroid. If there is rapid growth along with pain, then it is suggestive of thyroiditis. And coming to associate symptoms, symptoms of compression and obstructive symptoms such as hoarseness and dysphagia to be noted. And whether there is symptoms of hypo or hyperthyroidism. Hypo includes weight loss in spite of increased appetite, heat intolerance, tachycardia or palpitations, anxiety, irritability, or insomnia. And symptoms of hyperthyroidism such as weight gain in spite of decreased appetite, cold intolerance, bradycardia, constipation, depression or fatigue, and all these symptoms to be evaluated. And coming to diet, uh, diet is important as follicular and anaplastic carcinomas are more relatively common in iodine deficient areas. And coming to radiation exposure, patient with history of radiation exposure to the neck are at high risk for development of thyroid masses. And about 70 to 95% of thyroid cancers occurring after radiation is mostly due to papillary thyroid carcinoma. And this radiation exposure, if it is at the younger age and if it is of longer duration and if it is associated with female gender, there is significantly high risk of papillary carcinoma in these patients. Next, coming to physical examination, complete systemic examination for features of hypo and hyperthyroidism to be done, and local examination of thyroid with size, site, its shape, consistency, and presence of any other palpable nodules to be done, and complete neck examination to evaluate for the palpable lymphadenopathy to be done. And biochemical tests include thyroid profile. If a patient hypothyroidism is confirmed, then to do the thyroid antibodies. And if there is positive family history of medullary thyroid carcinoma, serum calcitonin to be done. Coming to radiological evaluation, ultrasound, it is used for identifying the metastatic lymph nodes and to evaluate the thyroid bed for local recurrence after the treatment. And it is also used for serial follow-up of a nodule, especially if nodule size is less than 1 centimeter. And it is also the investigation of choice along with FNAC if lesion is less than 1 centimeter. The
No,
features of
Praveen, malignancy, metastasis, and all that is later. Primary role of
yes, sir.
ultrasound is what? To detect the nodule. It's what is the type of nodule, whether there is any solid component within the nodule. So all that you have to tell, and then you have to go for identifying metastatic lymph nodes. Ultrasound is done to identify the lymph node, identify one, whether it is a single solitary nodule or whether there are subclinical or or the subclinical multiple nodules which are not clinically palpable.
Yes,
You
sir.
understood. So whether it is a part
Yes,
of
sir.
a MNG where the other nodules are not palpable or whether it is a solitary nodule. If it is solitary nodule, what kind of a nodule it is? Whether it is cystic, whether there is solid component, what it is, or whether it is just a colloid cyst. And then to guide the FNAC as well, and also lymph nodes. If once you suspect there are any cancer features in the nodule, and also then lymph nodes, if there are any lymph nodes.
Yes,
So it is the
yes.
first this thing is not lymph nodes, that comes later.
Uh, yes, sir.
Hmm. Continue.
Yes, sir. In the ultrasound, the features associated with risk of malignancy are microcalcifications, hypoechogenicity, irregular margins or no halo, if there is solid component, increased intranodal vascularity, and more tall than wide. Uh, Here, this is a picture of ultrasound, and this arrowhead shows the thyroid nodule, and this is hypoechogenicity, suggesting of suspicion for malignancy. And to differentiate between low risk and high risk, that is benign and malignant nodule, in the ultrasound, margins will be poorly defined in malignant and it will be of irregular shape with microcalcifications and hypoechogenicity with solid structure, and there will be central increased vascularity along with lymphadenopathy. Based on this ultrasound, based on 5 components, that is composition, echogenicity, shape, margin, and echogenic foci, thyroid scoring was developed. And based on this, each component scores are given. If there is 0 score, that is thyroid 1, thyroids 1, suggesting of benign, and FNAC is not required. If it is 2 points, then it is not suspicious and no FNAC is required. If it is 3 points, it comes under thyroid 3, it is mildly suspicious. And if nodule is greater than 2.5 centimeters, then FNAC is required. And if it is greater than 1.5 centimeters, then follow-up is required. If it is 4 to 6 points, then it comes under thyroid 4. It is of moderately suspicious. And if nodule is greater than 1.5 centimeters itself, FNAC is required. And greater than 1 centimeter nodule requires follow-up. If it is 7 points or more, it is thyroid 5 and it is highly suspicious nodule. And if it is greater than 1 centimeter, FNAC is required, and greater than 0.5 centimeter requires follow-up. Coming to next modality, CT scan or MRI. These are used for to evaluate the large malignant goiters and if there is any substernal extension and invasion of surrounding structures around the thyroid such as esophagus, larynx, or trachea, and to detect whether any nodal metastasis in neck or mediastinum is present. Coming to isotope scanning, the usual indications for thyroid scanner if to detect any residual or recurrent disease after surgery, and if there is low TSH and features of hyperthyroidism, and if there are any ectopic or aberrant thyroid. It is usually done with uh, two two categories. It will be of technetium 99 or radioactive iodine. In technetium 99, we can know only about the information about the uptake, but in iodine 123, you can know info about uptake along with organification. Here, we can see the cold nodule is in the first picture. Cold nodule is suggestive of non-functioning nodule, and there is 20% risk of cancer. In the below picture, you can see the hot nodule. It is a hyper-functioning nodule, and there is about 4% risk of cancer. This hot nodule can be of single. It can, if it is single, it is termed as solitary nodule, and if it is multiple, that it is termed as toxic multinodular goiter. And this picture suggests of Graves' disease as there is diffuse increased uptake. And the last picture is suggestive of thyroiditis as there is diffuse decreased uptake of the iodine. Next modality is fine needle aspiration cytology. It is the most safest and cost-effective and reliable technique to differentiate between malignant and benign diseases. And its sensitivity is around 90% and specificity of 70%. But there is false negative ranges from 1 to 5%. It is usually associated with cyst or nodules which is smaller than 1 centimeter. The usual needle used is 23 to 30 gauge, and it is classified, the histology is classified according to Bethesda system of classification. But the limit of FNAC is it cannot distinguish between follicular adenoma and carcinoma. The subcentimeter nodules, which should be biopsied only if there is more than one suspicion of ultrasound characteristic, or if there is extracapsular growth or abnormal cervical lymph nodes, or there is high risk of history. And this is the table suggesting the features which and its nodule threshold which is required for FNAC. In the high risk category, if the nodules are suspicious, then minimum nodule size required is greater than 5 mm. And if in the abnormal if there is abnormal cervical lymph nodes, then all sizes of nodules can be taken for FNAC. If there is microcalcification present in the nodule, then greater than 1 centimeter is required for FNAC. And if nodule is solid, if there is solid nodule along with hypoechoic, then greater than 1 centimeter is required for FNAC. But if it is iso or hyperechoic, then greater than 1.1 to 1.5 centimeters required. And in mixed cystic and solid nodule, if without any suspicious features, then 1.5 to 2 centimeters is required. With suspicious, yes, sir.
You keep saying it's required. It's not required. It is the
Recommended.
you need to biopsy. It is not required. Even
Yes.
if it is, 0.8 centimeter by 8 mm also, if it is suspicious, you will do an FNAC. So it is not required to be 1.1 mm. If it is that size, that it means that you need to do it. That's all.
Okay, sir.
Okay, carry on.
Yes. And, this table depicts the Bethesda classification. If there is score 0, it is non-diagnostic, and there is no risk of. It requires repeat FNAC, and score 1 depicts the benign. It requires follow-up by ultrasound, and there is only 0 to 3% of malignancy risk. Score 2 defines ATP of undetermined significance or follicular lesion of undetermined significance. It requires repeat FNAC, and there is about 5 to 15% risk of malignancy. Score 3 depicts suspicious for follicular neoplasm, and it might require surgery of lobectomy or hemithyroidectomy, and there is about 15 to 30% risk of malignancy. Score 4 depicts suspicious for malignancy, and it also requires surgery of hemithyroidectomy or total thyroidectomy, and the risk of malignancy is about 60 to 75%. And score 5 depicts malignant and requires surgery of total thyroidectomy, and the malignancy rate is of about 97 to 99%.
This is about FNAC you're talking about.
Yes, sir. FNAC, sir.
Hmm.
And these are the cytology pictures of after FNAC. Here there is sheets of follicular cells shown in as taken in the goiter. This FNAC is of papillary carcinoma of thyroid. Here you can see the papillary formations and characteristic samoma bodies along with nuclear pseudo inclusions, which is known as orphanine nuclei, and nuclear growths along with central clearing. In medullary carcinoma, this is a FNAC picture showing intracytoplasmic granules along with plasmacytoid cells. And this is a picture of amyloid deposit. Here you can see the apple green birefringence, and it is on the background of Congo stain. And here you can see the follicular pattern of cells. There will be overcrowding of cells with a follicular type of pattern. And there are various risk assessment scoring systems such as AMES, age, metastasis, extent of primary size of tumor, AGS, age, grade of tumor, extent of primary size, and masses, metastasis, age, completeness of resection, invasion size. But
No,
these
no,
are all of
Praveen, wait,
old
hold on. Is this risk assessment in thyroid nodule or is it risk assessment in well-differentiated thyroid cancer?
cancers, thyroid nodal
Ah,
cancers. Yes,
then you're talking about a risk assessment in thyroid nodule. It is not risk assessment in thyroid nodule. Sir,
yes.
I think it is malignancy.
it is risk assessment in well-differentiated thyroid cancer to decide on the type of surgery you do. It is basically for that.
Okay, sir.
Go on, explain.
But now recently it is all under the AGCC 8th edition guidelines, which is used for the assessment and staging of the thyroid tumors. This is the flow chart to summarize methodology. If there is low TSH, then the next step will be the thyroid scan, and to know whether it is in hot nodule or cold nodule, then management will be of thyroid suppression and monitoring the patient and a 6-month follow-up. If there is failed suppression, then it requires of radioiodine ablation or hemithyroidectomy. If it is TSH is normal, then we'll go next step will be of ultrasound USC, and in USC if the nodule is of benign, it requires of follow-up. If the benign nodule is of cystic, will aspirate the nodule and will keep the patient under follow-up of 3 to 6 months. If it is
Aspirate
malignant,
the cyst.
then
Aspirate the
sir,
cyst. If it is cyst, then you aspirate, not nodule.
yes, sir.
Yeah.
Yes. Uh, if uh, if there is nodule, a patient will be kept under follow-up of 3 to 6 months. If there is any growth and if patient having discomfort features, then we'll be planning for the surgery. If nodule turned out to be malignant, or if it is follicular neoplasm, then the management will be of surgery.
So
Can
that,
I continue?
so what is the role of frozen section?
Sir?
You have put there frozen section. So what is the role of frozen section? Where do you do frozen section?
Sir, in the ultrasound, if you are suspicious,
What is the role of rosal section, man? Is it for lymph nodes? Is it for the nodule?
When do you do
For
frozen section?
nodule,
Sir is asking.
sir, for nodule, sir.
So what? Explain when will you consider doing rosal section?
Sir, if ultrasound is if ultrasound is normal, but patient has suspicious features such as if features of malignancy or which are
Okay,
not correlating with
normal.
ultrasound.
How can the
Sir,
ultrasound be normal in patients who are suspicious? What suspicious features are you talking about? Are you talking about suspicious features in FNAC, suspicious features in radiology, or clinical?
radiology, sir.
Then
Praveen, you just now said all that.
you said ultrasound.
Bethesda, when you when FNAC suggests that there is follicular lesion, you just now told no previously. How can you
Yes,
suspect
sir.
malignancy in ultrasound which cannot be confirmed with FNAC? You have to do FNAC and
Follow.
then you take them up for surgery, right?
Yes, sir.
Sir is asking that only.
See, for all clarity purposes, see the thing is, frozen section is used in patients who have suspicious papillary neoplasm. Because or suspicious medullary neoplasm, medullary carcinoma, in case the levels of calcitonin is not suggestive or not conclusive, but you are suspecting medullary carcinoma, then you may want to do a frozen section. But in patients with follicular carcinoma, there is no role for frozen section because they can't with confidence talk about capsular or vascular invasion, even on frozen section, because those features can be masked by the cryostat. So, for follicular neoplasms, no role for frozen section. Lymph nodes, you can use frozen section if the features on radiology, that is ultrasound, and FNAC is not conclusive, but radiology suggests that it may be malignant, then the lymph node for frozen section confirms whether it is involved, and then decide whether you want to do a central compartment or a modified radical necrosis. So that is the role for frozen section. Follow?
Yes, sir. Understood.
Niranjan?
Yes, sir. Correct. Go on, Praveen. Wait.
Next will be the
Before going to this one, anybody has any doubts or questions or clarifications?
Sir,
Nikita? Sania, yes.
with a malignant nodule, sir, is there when is the role for CT neck or
Praveen.
MRI of the neck, sir, indicated?
Good question. Praveen?
sir. If it is larger size and if there is retrosternal extension, and to assess the lymph node status, CT is required, sir. CT or MRI.
Why do you need for lymph node
Sir.
neck ultrasound scan is good enough?
When you're suspecting something else.
Tanya, you only give the answer.
Sir, I was not sure. This is the doubt I had wanted, because I knew it is if it is in a malignancy, if it is like he said, large size and like retrosternal extension. But if it in small nodules, if it is malignant with ultrasound showing lymph node positive lymph nodes, to be
In
go
those
ahead with
in
CT,
those
sir.
scenarios, generally it is not recommended. You
Okay.
do CT or MRI only when there is locally advanced where you're suspecting invasion of any surrounding structures or retrosternal.
Okay.
Yeah.
Okay, sir.
Usually for lymph nodes, as sir told, ultrasound is good enough. And if you have a diagnosis with FNAC, you don't have to do anything else except straight away going for surgery. Only you're suspecting local invasion into adjacent structures or retrosternal extension, or if there is if there is an extension into mediastinum, or if there are some other things in the mediastinum, then you do CT.
And the large tumor, as Niranjan said, or if there is suspicion that it may be a anaplastic carcinoma, then you may want to do a CT. That's all. Otherwise,
sir.
you don't need CT.
Okay, sir.
Or sometimes lymphomas as a staging.
Lymphoma, correct.
Okay, sir.
Anyone else? Nikita?
No,
Vinod?
sir. No, sir.
Sir, also one
Nitya?
more doubt. He
Yeah,
mentioned in the blood investigations, he said when TSH is low, to get thyroid antibodies done. So
correct.
we'll have to get it. It is a common rule to get it done in everybody, sir.
Yes, you have to rule out no hyperthyroidism, whether it is Graves or something else. So
Okay,
thyroid
sir.
antibodies will guide you in that, and then you
Yes, sir.
can, if it is a solitary nodule, as you mentioned, you have to go for a thyroid scan.
Thyroid scan. Okay, sir.
Yeah, whether to determine whether it is a hyperfunctioning nodule or whether you have multiple,
nodule.
the whole of the gland is hyperfunctioning.
Yes, sir. Okay.
Sir?
Yeah, correct.
Okay.
So
So if no more,
the
yes, sir.
important, all of you start with the TSH. The TSH is the guiding principle for all the further investigation. So that is the most important thing you should know. Okay. Carry on.
Yes, sir. Next topic will be the multinodular goiter. The hypothesis was stimulated by David Marine and Taylor. They suggested that multinodular goiter is due to a result of chronic low-grade intermittent stimulus to thyroid hyperplasia. It is a continuous cycle. When there is iodine deficiency due to TSH stimulation, there will be period of hyperplasia. And when there is slow iodine repletion, thyroid goes to in a resting phase, which is characterized by colloid storage. And if it is continued by iodine deficiency, then it is followed by the hyperplasia, and the cycle go on, which forms a multinodular goiter. In etiology, the primary factors are functional heterogeneity of normal follicular cells, most probably due to the genetic and acquisition of new inheritable qualities, and due to subsequent functional and structural abnormalities in the growing goiters. Secondary factors include elevated TSH. It may be due to iodine deficiency or due to natural goitrogens intake or inborn errors of thyroid hormone synthesis due to smoking, stress, thyroid stimulating factors, and endogenous factors such as gender. And these are the various goitrogens which is associated with multinodular goiter. And
What about Hashimoto's, man?
sir,
You have not included Hashimoto's in the etiology of multinodular goiter.
so in this I have written inborn errors of thyroid hormone synthesis, sir.
That's not an inborn error. Hashimoto's is a
Acquired.
not inborn error.
Yes, sir.
Okay, carry on. That is actually the most common for multinodular goiter, apart from iodine deficiency, which is now becoming almost obsolete because iodine supplementation is happening in every country, every place. So
Yes,
I
sir.
don't think there are endemic areas now anymore for thyroid deficiency and iodine deficiency.
Okay, sir.
Now I think the Hashimoto's is the most common cause for multinodular goiter.
Yes, sir.
Okay, carry on.
And coming to symptoms and size, mostly they'll be of family history of benign thyroid disease and complaints of slowly growing anterior neck mass, and there may be sudden transit pain or enlargement secondary to hemorrhage, and rarely present with upper airway obstruction or dyspnea or cough and dysphagia suggestive of obstruction features, and gradually developing hyperthyroidism features. And there will be nodularity on examination, asymmetry, tracheal deviation or compression. Really, there will be recurrent nerve palsy signs. And around 4 to 17% of patients presenting with signs of multinodular goiter have a carcinoma. investigations to detect multinodular goiter, it will be started by the thyroid stimulating hormone. It might be normal or decreased, and thyroid scan, which may suggest of multiple hot and cold areas, and ultrasound features of solitary or multiple nodules with varying echogenicity, and final aspiration, which also shows dominant, solitary and dominant nodules. And same as
Praveen,
to solve that
let us-
is
Let us go back to the basics. How do you
Yes, sir.
define, how do you clinically define a multinodular goiter?
uh,
I have worded my question
definition.
correctly. How do you clinically define a multinodular goiter? If you don't know, pass it on, somebody else. Vinod,
Palpable multiple nodules.
pardon me,
Palpable multiple nodules.
correct, and so that is one definition. If you can palpate when you clinically palpate thyroid, multiple
More
nodules
than,
palpable, okay, that is one definition. Other one,
more than one palpable nodule in an otherwise non-palpable gland.
no, that will become solitary nodule.
More than one
Diffuse
palpable nodule.
Anybody, Nikita,
single nodule
That
in
is,
one lobe and diffuse enlargement of the whole gland will also be considered as multinodular goiter, sir.
correct. One palpable nodule with an enlarged, otherwise not nodular, is also a definition of multinodular goiter. If you can palpate multiple nodules, then it is obvious. Otherwise, if there is a palpable nodule, but an otherwise enlarged non-nodular thyroid, even that is considered to be a multinodular goiter. Okay, carry on.
Similar to the thyroid nodule, evaluation will be started with the TSH. If it is slow, then we'll be doing the thyroid scan to detect whether it's of hot nodules or cold nodule. And if it is normal or elevated, then we'll be doing the ultrasound followed by FNAC. And if it is benign, we'll be asking the patient to come under a follow-up in 3 to 6 months. If there is any pressure symptoms, then surgery is advised. If it is suspicious or malignant, then surgical excision is required. And
Praveen,
part of
what is the commonest malignancy in MNG?
papillary carcinoma, sir.
Follicular
Okay.
neoplasm.
No. It is
Papillary,
papillary.
sir.
Commonest is papillary. Second commonest is follicular variant of
Follicular.
papillary. Then comes follicular. And what is the prevalence of malignancy in MNG?
4 to 17%, sir.
It varies. Earlier it was 5 to 10%. Now it recent literature shows it is up to 22%. So it is very
Yes.
high.
Yes, sir.
Earlier the thing was you can wait and watch, but now you even in multinodular goiter there is 22% chance maximum of it turning into malignancy. So that is also one more indication for advising surgery in a case of multinodular goiter. Because you are saying asymptomatic, that is why I said, sir.
Yes.
Yeah. See I think again there, the size of the gland is important. If the size is one of the
Commonest malignancy.
2 centimeters, then definitely surgery is advised.
Commonest malignancy.
Hello, somebody is saying something?
Who was that?
Somebody said commonest malignancy.
Yes, that is what I have also heard the voice.
Yeah.
Anybody wants to chip in? Who was that? Okay, sir, I think no. You
Yeah.
can continue. You're telling something.
No. I think I heard that voice. I wanted to know who that was. Yeah, carry on, Praveen.
Coming to other variant, it is plumber disease. It is similar to multinodal goiter. It starts with chronic low-grade intermittent stimulus, which is leading to diffuse hyperplasia of gland and forming of nodules or multiple nodules. But there is autonomous activity of these nodules, which will be independent of pituitary TSH feedback, which leads to toxic multinodular goiter. The hallmark feature is there is true functional autonomy with disordered structural and functional heterogeneity. And the proposed pathophysiology is that there might be somatic point mutation in thyroid stimulating hormone receptor, which causes activation of this receptor in absence of TSHSO. And it will be presented as features of hyperthyroidism, such as heat intolerance, weight loss, tremors, palpitations, increased blood frequencies, excessive sweating, sweaty palms. And on the evaluation on the thyroid function test, there will be low TSH levels as there is hyperthyroid and T3 and T4 are elevated. In ultrasonography, there will be background of cold, hot nodules along with cold nodules. The management will be started with anti-thyroid drugs and followed by surgery. After surgery, patient will be supplemented with a thyroxine supplementation. Patient might also be given an suggestion of radioiodine ablation. And for short-term outcome, ethanol ablation is also preferred method for plumber's disease.
Okay. Anybody has any questions? Nikita, Vinod?
Sir, I have a question. I didn't understand the part where frozen section will be useful in medullary cancer, carcinoma thyroid. Like usually, I have heard that follicular, we do a hemothyroidectomy, send it for frozen section, and then in case if it is turning out to be malignant, we do a completion thyroidectomy. But now this medullary thyroid and that papillary thyroid, that part I want a clarification, sir. Like I want to know.
No, that is what even in as sir explained, when there is a suspicion of cancer, when it is not sure about
Okay.
cancer on FNAC, you when as per his Bethesda classification in that I think gray, what is that fourth this thing, 3 or 4. So in that
Four, sir.
scenario where there is suspicion of cancer, but it is not neither benign nor cancerous. If it is obviously on FNAC, if it is papillary CA, you don't have to do. On FNAC, if it is you're absolutely sure medullary, you don't have to do frozen. Okay. In the disadvantage of doing frozen in a follicular neoplasm, as sir said, capsular invasion cannot be accurately predicted even in frozen section. Okay, if it is very obvious, they will say sometimes, but most often it is indicated for lesions where there is suspicion of malignancy. Okay, it need not be papillar, it need not be medullary, it need not be follicular. When it is in falls into that gray zone where you suspect malignancy, in those cases you clearly go for frozen section. Otherwise, if there is absolute clarity on FNAC diagnosis, you straight away go and do the surgery. There you don't have to do frozen section. In follicular, when FNAC says it is follicular neoplasm, in those scenarios, even if you do frozen section, as sir was telling earlier, that you cannot predict accurately because you can miss the capsular invasion even in on frozen section. So it is not to indicate. I hope you understood. I think sir can also clarify.
Understood, sir.
Yeah. Sir? Ravishankar sir? Sir has left, huh? Hello?
Sir left, sir, but he joined again from another account. But
Okay.
he's unmute and like he's not
Okay.
he's muted
Yeah,
himself.
Fine, fine. Anybody has any more questions? Any clarifications?
Yes, I just wanted to know after all this discussion, what are the exact indications of radioiodine scan or radioiodine therapy, sir?
No. Those two are totally different. What you want
Yes,
to
sir,
know?
yes. Both.
You're talking about thyroid scan or you're talking about radioiodine therapy? What you want to know?
So both, sir,
They are two
because
different
different
things.
places I'm finding different indications for it. That's it.
No, it is absolutely clear. Praveen, you want to take that question?
Sir, radioiodine scan is indicated when there is low TSH to differentiate between hot and cold nodules. We'll be doing the radioiodine scan.
No.
Sir,
If Praveen, you're getting confused. We don't do to differentiate between hot and cold nodules. When TSH is low, you want to, and you have done your thyroid antibodies and all that, you do only that TSH, this thing, it is not to differentiate between hot and cold nodule. It is to differentiate whether the gland is hyperfunctioning or whether a nodule is hyperfunctioning or
not
there are more than one nodules which are hyperfunctioning. That is the indication for radio
thyroid scan.
iodine
The
scan.
scan.
You don't do not radio iodine scan, thyroid scan,
Thyroid scan.
Technetium 99.
technetium 99. Radio iodine
Okay,
scan
sir.
diagnostic is not done in India because I-123 is not available generally. So radio
Okay,
iodine,
sir.
when you talk about radio iodine, it is for therapeutic purpose more often.
Hmm.
Okay,
That is.
so
Okay, sir.
so that is the difference, basic difference. So you avoid doing a thyroid scan until and unless
Hmm.
there is a toxic nodule or a toxic goiter or whatever. So you are where you have to differentiate what is producing the hyperthyroidism, whether it is an entire
Toxicity.
gland, whether it is a nodule, or whether there are multiple nodules. Okay, so
Okay, sir.
you don't
Yes, sir.
do thyroid scan to difference between a hot and cold nodule. That is no more indicated, sir.
Yeah. The radio iodine scan is only done post-operatively. What they do is they give us low dose initially because, as Niranjan said, and as I've been telling before, iodine 123 isotope is not available in India. So to overcome that, they gave a low dose iodine 131 to diagnose any residual nodules either in the operated site or in the lungs or in the lymph nodes or any other, for example, if it's a follicular neoplasm, if there is cerebral or bony metastasis or whatever, and then target the radio iodine 131 as a therapeutic dose if they pick up anything. So what you do in those cases is you starve the patient of thyroid for a period of maybe 4 to 6 weeks till the TSH comes up at least to 30 or more, and then do the radioiodine scan. So that is the only indication for radioiodine scan. As Niranjan said, the other scan is the radioisotope technetium 99M scan, which is used to differentiate between solitary nodule, functioning multinodular goiter, or Graves' disease.
It is not done in
Okay,
other
sir.
benign conditions, like to diagnose whether it's a hot nodule, cold nodule. That doesn't hold any significance.
And other
Or
indications, Sania, is if there is a mediastinal goiter, you want to know whether it is a functioning goiter or non-functioning, then you can do an iodine, this one radioisotope scan. It will light up if it is a functioning thyroid. This one.
that
Sometimes,
and also ectopic thyroid.
yeah, ectopic thyroid. Yeah,
Hmm.
mediastinal ectopic
Okay, sir.
thyroid.
So those are the only indications. I hope your doubt is
Yes,
clarified.
yes, sir. Yes, sir.
Yeah. Anyone else? Ainas, Nikita.
See, thyroid is a common case that is there. If there is a thyroid case in the ward, they will keep it. So you should know how to scientifically approach the thyroid nodule, whether it is a solitary nodule, multinodular goiter, and you should be able to elucidate the clinical symptoms and signs, and also the pattern of investigation, and you should scientific and justifiable way of investigating these patients. So it's very important. So if you have any doubts, please clarify now.
Sir, I think there are no doubts. Your comments, sir? Final comments.
I think Praveen, you presented well. I think the slides were good. The flow charts were also quite good, and I think you have made effort to get good data from I think across the literature that is not just textbooks. You have quoted from articles, I think journal articles also, and your presentation was quite clear. Good. I think you were quite impressive.
Thank you, sir.
So I think that's probably what I have to say.
Yes,
Thank you,
sir.
sir.
I also agree.
Final comments. Yeah, final comments.
I also agree. I think Praveen, you presented well, and your slides are also good, and you had used a lot of references. So out of the textbooks, more the content was more from journal articles. Keep it up.
Yes,
Good.
thank
I
you, sir.
think,
Thank you,
Thank
sir.
you.
Praveen, the only thing I think maybe that is more relevant for somebody who is actually going to talk about malignancy, the AJCC 8th edition, what are the differences? I think those things have to be highlighted, but probably by the person who is going to deal with the malignancy.
Yeah. That is why he has not
Yeah.
put it up.
Yeah.
Thank you, sir. We'll end it then.
Good night.
Good night.
Thank you, sir.